Yes, ma'am.
Okay. So we'll start with the OSCE. So coming to the first OSCE, the first question is name the test. You can start answering in the chat box. Name the test. Which test is being shown out here? Yes, it is BERA. So most of you are right. We are talking about a BERA. Coming to the next question, can you localize the waveform as per the neurology? Can anyone enumerate the waveforms that are being shown out here? 1, 2, 3, 4, 5. What are these waveforms? What are they meant for? Do they specify anything? Wave 1 is for what? Wave 2 is for what? We all have read about this in our MBBS time. Any guesses? E. coli. Yeah. Yeah. Somebody has answered it right. It is E. coli. So, can you actually, somebody can write E. coli? What is the full form of E. coli? Three is for nerve. Okay. Something better? Okay. Eighth nerve. Yes, right. Cochlear nucleus. C is cochlea. Inferior colliculus. Yes. Okay. So somebody has written nicely the complete answer. So we'll just go through the answers a little later. But yes, some of you have answered correctly. First is cochlear nerve. Second is again the cochlear nerve proximal end. The third is the cochlear nucleus. Fourth is superior olivary nucleus. And the fifth one is lateral lemniscus. So we'll go through it once again. What is the expected hearing abnormality in a case of bind? In a case of bind, what is the expected abnormality that you expect? Yes, most of you are answering rightly. Sensory neural hearing loss. But if suppose, yes, you are absolutely correct. It's the sensory neural hearing loss which is associated. But if I talk about this BERA, what changes are you going to expect in this BERA? In this waveforms, what changes I'm going to expect? Okay, somebody has written the loss of morphology of fifth wave. Yes, yes, correct, correct. So you are going to see that there is going to be a decrease in threshold and the latency of all the waves. So remember two things, threshold and latency, it is going to get decrease. Okay. And conduction time is going to get increase. Okay. So just remember these 4 points. One is will be a decrease in threshold of all the waves because there is a loss of hearing. So all the waves threshold will decrease. Then the latency will also increase. There will be increase in the conduction time. And there is something which is shown here. You can see the inter-peak latency. These inter-peak latencies between first and third and first and fifth, it is going to increase. Okay, so this is something which is, a sort of memorizing sort of a question, but you should remember it. But that in a case of a bind, this is something which is a very, very important test that we should all know what changes we have to see for. So as I said, there will be a decrease in threshold, decrease in latency. There will be increase in conduction time because this is something which, comes automatically, that conduction is actually getting decreased. So the conduction time will increase. And these inter-peak latency, these are inter-peak, first and three peak latencies, this first and fifth, these distance will also increase. Okay. The last question is, till what age should such neonates be followed to rule out the hearing loss in a case of bind? Till what age we should follow such neonates? 6 to 8 years. Okay. Any specific age group? Anyone wants to guess? Yes. Yes. Somebody has answered 5 years. Yes. This is correct. So, such neonates need to be followed till 5 years. So, we'll go through the answers of these questions. First was the Paratus, which most of you have guessed correctly. The waveform morphology. So, these are certain waveforms. So, this is how we remember during our UG times, E. coli, that was cochlear nerve, the cochlear nucleus, the olivary nucleus, the lateral lemniscus, and the inferior colliculus. COLI. Okay. Then in the bind, this I told you that there will be a decrease in threshold, decrease in latency, increase in conduction time, and increase in the interpeak latency. And we cannot leave these neonates unattended. They have to be followed till 5 years of age. Okay. Okay. I hope all of you can guess this curve. Name this curve, x-axis and y-axis. ROC curve. Okay. ROC curve is correct. What about x-axis and y-axis? What is x-axis and what is y-axis? Okay. Yes. So x-axis represents sensitivity and the y-axis represents 1 minus specificity. It is not sensitivity. X-axis is sensitivity and y-axis is 1 minus specificity. Okay. So this we have already discussed, sensitivity and specificity. What are the two things that you can actually infer from such tests? You might have seen these ROC curve being many of the papers and all. So what things that you actually interpretate? Yes, somebody has written diagnostic accuracy. Yes, correct. What else? You would have read this in many papers. Cutoff values. You have read now? You would have read something area under the curve. Have you heard about this terminology, area under the curve, which you might have come across in many of the journals which you present in day-to-day life? What is DOR? Can somebody has written DOR? What is this? Can you just elaborate? Diagnostic odds ratio. Okay. Okay, so we'll go through the answer. I know it's something which is related to statistics, which most of us don't like. So ROC curve, x-axis, remember it is sensitivity, y-axis is 1 minus specificity. In an easier term, sensitivity is true positive and 1 minus specificity is false positive. The things which we can actually accurately assess and continue assessing and infer from these graphs is the cutoff values. You can compare two tests, which is better than the other. Then by area under the curve, as one of the participant even said that it is going to tell you regarding the overall diagnostic accuracy and you can choose a cutoff point. We all have read about certain cutoff points like a procalcitonin cutoff point, CRP cutoff points. They all come from these ROC curves. Okay, this is an easier one. Describe the imaging findings. What you can see in this image. Plick, no, there is no plick which is visible. Something better? You can easily identify this. Just try to focus on the image. Don't go for very hi-fi thing. It's a very simple one. Try to assess the lobes. Try to assess what you can see in the various lobes. Post-leukoencephalopathy. Something closure. Yes, somebody has answered now. It's a hypoglycemia. There is a hyperintensity which is seen in the occipital region. Okay. So somebody has answered all the three questions in one line only, I think. So this imaging modality, it's the occipital region. See this occipit. There is a hyperintensity which is seen in the occipital region. Okay. And the most probable etiology we all know related to hyperintensity in the occipital region is what? What's the most common etiology? Yes, it is hypoglycemia. Okay. When we talk about a sequelae, which sequelae we are worried about with this occipital lobe hyperintensity? Yeah, we are worried about the visual loss. We are worried about the cortical blindness in such neonates. So most of you have answered this question correctly. It's a occipital lobe hyperintensity. There was a hypoglycemic injury and we are worried about the visual characteristic of this baby. Okay, identify these lines. What is line A? What is line B? Okay. Mm-hmm. Okay. Let's start with A. You can see this A line. Uh, how do you identify artery and vein? So artery usually dips and then goes up. The vein directly goes up. Okay. So yes, most of you have guessed correctly. A is artery. Why A is artery? See, it is dipping down and then going up. So this is dipping down and going up. So this is an artery. So A is a artery and vein, this is a vein because see, this is going from here. This is going straight up. So this is vein. I know it is malposition. We'll talk about in the subsequent questions. So A is artery, B is vein because artery is dipping down and going up. Vein is directly coming and going up. Okay. So coming to the next question, can you tell what is the correct anatomical position for B? What is the correct position? Most of you have guessed correctly that it is malposition. But what is the correct anatomical position for this? Yes, it is just below the diaphragm or it's at the level of the diaphragm or above the diaphragm? Yeah, it is above. So it is usually just above 0.5 to 1 centimeter, just above the diaphragm and not below it. Okay. So can you tell any complications which are associated with these lines, even if it is in place also, but there are certain complications which we all are aware of. Can you tell some of the complications? Yes, the most dreaded one, most of you have written sepsis. Sepsis is the one of the most dreaded complication, even of any central lines. We all are aware of. Infections, yes. Anything else other than infections? Portal vein thrombosis, very good. Thrombocytopenia, thrombosis, liver necrosis if it is malposition, iatrogenic hypoglycemia, very correct. Pneumobilia, again, this is one of the issues related to malpositioning. Arrhythmias, yes. So most of you have answered this question also correctly very well. A was an artery, B was a vein. We talk about the correct anatomical position. The umbilical venous catheter should be placed in IVC. above the ductus venosus and the hepatic vein, but below the right atrium. So that comes to 0.5 centimeter to 1 centimeter just above the diaphragm, not below the diaphragm. And these are certain complications which most of you have discussed, that there is a risk of thrombosis, embolism, infarction, sometimes even uh, the refractory hypoglycemia if your catheter lies in the celiac axis. Then if there is a malpositioning, there is a risk of peritoneal perforation, aneurysm, and sometimes a dislodgement as well. Okay, we'll go ahead with the next question. Okay, can anyone guess what is the finding in this image? Calcification, yes. Something more? Yeah, hydrocephalus. Yes. Any more guesses? Ventricular dilatation. Somebody's also answered torch. Yes. Abscess, I will disagree. There is no collection as such. Ventriculomegaly is definitely there. Ventricular dilatation is there. Okay. So you can see these white color spots. Yeah. So they are the calcifications. And there is a ventriculomegaly which is also seen. Okay. 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 This classically represents in which clinical scenario? Yes. It is commonly seen in the case of toxoplasmosis. You can see the calcification areas. They are seen in toxoplasmosis. Okay. Coming to the next question. What is the treatment which is given to the mother if it is suspected antenatally? Spiramycin before 12 weeks. Okay. It's okay. Trimethoprim sulfamethoxazole. Okay, most of you have guessed rightly. So it is pyramycin followed by trimethoprim sulfa drugs along with folinic acid. So if we talk about the postnatal treatment, can you tell what is the drug of choice in the postnatal case scenario? Pyrimethamine, sulfadiazine, what else? Folic acid, yes. Okay. So, hydrocephalus with diffuse calcification, again a feature of toxoplasmosis. In a pregnant woman, spiramycin is a drug of choice for the first 21 weeks. It was not 12 weeks, it was 21 weeks. And then later we can continue with pyrimethamine and sulfadiazine along with leucovorin. In the case, if you talk about the postnatal treatment, you give a pyrimethamine with sulfadiazine, leucovorin, and steroids if it is a case of active chorioretinitis or if the CSF protein is raised. And the treatment in the case of a neonatal age group, it is quite long, requires a lot of follow-up till 1 year of age. Okay. Okay. Next, coming to the next question. Can you identify this condition which is being visualized in this? And the phase that is represented in this? Stereotheral wall, BUR. Somebody said boy, filling phase. Think more about it. Does it look like a filling phase? Okay. So yes, you are right. You can see that there is a posterior ethereal wall. There is a ballooning scene and there is a thin stream which is there. So actually this film was taken during the voiding phase and not during the filling phase. Always remember to see this stream whenever you are looking and telling that whether it is a filling phase or whether it was a voiding phase. Okay. What is the treatment option that is available for this posterior urethral wall? Fulguration, right? What immediate treatment that you give? Immediately when the baby comes to you. Fulguration will take a little time. Catheterization. Yes, you have to do even the catheterization and followed by ablation. Okay. Can you enumerate what is the prognostic factor for long-term outcome of this condition? What everything depends upon? Hydroureteronephrosis, RFTs, yes. So we are all worried about the kidneys, creatinine, okay. Yes. So it is the renal things which we are worried about. So we are more worried about renal parent. Yes, somebody has answered renal parenchyma thinning. Right, right. So it is the renal parenchyma. We are worried about renal dysplasia, and that is ultimately going to cause the disruption in your creatinine and the further KFT values. Okay. Can you tell what are the risk factors which are associated with this condition for progressing to end stage kidney disease? You have already answered this in your previous question. Renal scarring, yes. Yes, loss of corticomedullary junction, dysfunction, the corticomedullary junctions. Okay. So we are basically worried about the kidneys, but there are certain factors. VUR, yes. Nutrition, not exactly, but yes, we are worried about the VUR. So we'll go through the answers for this question as well. So it's a posterior urethral wall. What we do immediately, it's a placement of a catheter. You might try ablation, but there are cases where we won't be able to do the ablation. So what we do the vesicostomy. Okay, if you are not able to do any of such procedures. Then we are worried about a renal dysplasia as an important prognostic marker because we are all worried about the kidneys. And when we talk about a specific risk factors, if you read about VUR, they have given these three as a specific risk factors which will make them progress to the end stage renal disease. So whenever you are answering the question of an OSCE, you have to be really precise in answering it. So when a KIRAT becomes more than one, or there is a bladder dysfunction, or there is a urinary tract repeated obstruction, that means you are ablating it and it's not getting corrected, and it is leading to recurrent UTIs. They are the four factors which decides your progression to ESRDs, what you call it as end stage renal disease. So a rising creatinine, a bad bladder, and a abnormality related to repeated obstructions or a recurrent UTI. They form your risk factor for the later development of end stage renal disease. Coming to the another question, can you describe the finding in this X-ray? Any guess that you can see what is there in this X-ray? Absent fibula. Actually, it's a little rotated one. It's not absent. Yes, somebody has started to pick up. No, epifemoral epiphysis. Yes, yes. Yeah, hypothyroidism. Yes. Were you able to appreciate the long bone epiphysis in this X-ray? Is there any long bone epiphysis which is visible? No, na? So this is the absent epiphysis of the long bones. We are not able to see the epiphysis of the long bones. Okay. So I think now you would be able to guess which condition we are talking about. So what are the diagnostic tests that you will be doing to confirm this diagnosis when there is no long bone epiphysis being visible? Any guesses on which diagnostic test you will be doing to confirm this diagnosis? Somebody has already answered this question previously. Yes, FT4TSH. Yes. So what follow-up advice is required for such neonates? Very, very important follow-up advice. What we usually haul for in such cases of hypothyroidism. Why we are so worried about hypothyroidism? Yes, you do a follow-up TSH, but what we are ultimately worried about? Yes, mental retardation, neurodevelopmental assessment. You are more worried about the brain damage. Yes. What medication will you advise? And when will you plan for re-evaluating such cases? Growth. Yes, somebody has answered rightly. Growth monitoring is again very, very important. Thyroxine. Yeah, we have to do thyroxine. We have to start this patient on thyroxine. How much is the dose of thyroxine that we will be starting? Mm-hmm. Is it milligram? Somebody has written milligram. Is it milligram? Yeah, it is 10 to 15 microgram per kg. Yes. And when will you plan to reevaluate? The first thyroid, once we have started the medication, when we are going to repeat it? Yeah, most of you have answered this question correctly. You have to repeat it after 15 days. So we'll just quickly go through the answers. There is absent of epicycles of the long bones. You are going to do the free T4 and the TSH. We require a neurodevelopmental, and of course, somebody has rightly said it. It is a growth monitoring also, which is required. We are going to start this patient on L-thyroxine. Dose you all have said correctly and reevaluate after 15 days. Okay. So can somebody tell what is the SMART aim in the quality improvement study? Can somebody, detailedly elaborate what a SMART aim means in the quality improvement? What is SMART aim? Okay, somebody's already started to answer it. Specific, measurable, achievable, resource, time. Again, if you're going to compile a lot together, most of you have guessed it correctly. So S stands for specific, M stands for measurable, A. Any guesses for A? Yes. Achievable. Yes. It is specific, measurable, achievable, relevant, and time bound. Okay, so there are specific, measurable, achievable, relevant, and time bound. So let's start guessing one by one. Can you tell what is there in figure 1? What is this figure 1? What is this figure 1? Yeah, somebody has told rightly. This is Pareto chart. So once you read quality improvement, you will come across certain figures. So this is something which you call it as a Pareto chart, means the most of the conditions are actually categorizing on the 80% of your issues. So yes, this is a Pareto chart. Second, yes, already the guesses have come for the second. Second is fishbone. Yes. Second is the fishbone analysis. Now come to the third guess. What is third? No, this is not 5 eyes. Somebody has written 5 eyes. This is not 5 eyes. This is the second is the fishbone. Now coming to what is this? Figure 3. What is figure 3? Root cause analysis. Okay. Something better. What you do in a root cause analysis? Can you see something which is written over here in the circle? Yeah, this is 5Y. Again, they are all the part of a quality improvement project. Okay. Now come to the last guess. What is this fourth one? Process flow, arrow diagram, PDSA. This is a process flow. So they are all the methodology of representing your quality improvement projects. So either you can do it by Pareto principle, you can do it by the fish chart, you can do by the 5 why based root cause analysis, or you can do this process flow chart. So they are all the, just to sensitize you people, I've just put this question just to sensitize you so that you can know a little idea about what is the quality improvement project is. And many of you would be doing even a fellowship may the short projects that you used to do even on the such principles as well. Okay, so these are specific, measurable, achievable, relevant, and time bound, and this we have already discussed. Now, this is something which you all are very fond about nowadays. Now, echocardiography. So, identify the abnormality which is visible in the first picture. I think this everyone will be very fond of answering. Yeah, PDA. Most of you have answered PDA. Okay, rightly answered. This is a patent ductus arteriosus. So can you identify the flow pattern which is shown in the above mentioned picture? This is a flow pattern. Can you identify what kind of flow pattern is being visible? Yeah, everyone is very fond of eco, it seems. Huh? Growing PDA. Yes, this is a growing PDA. You can see that there is both bidirectional flow is there, but right to left shunting is less and left to right shunting is more. So this is a growing PDA, unrestricted growing PDA. Okay. Coming to the next question, what parameters decide the hemodynamic profile for the treatment? How do you decide on the basis of the hemodynamic profile? What all parameters do you see in the hemodynamic profile for the purpose of treatment? Size, yes. Ductal size, 1.5, very good. LAAO ratio, rightly said, LAO ratio, size. Yes. Flow pattern, very good. LVEDD AO ratio, nicely said. Steel phenomena, very good. Reversal of the flow in descending aorta, again, somebody has rightly said about it. Yes. So most of you know about echo, I think, very well. Name a recent trial on the elective selective early treatment and what medication was used in that trial. A recent trial on the selective early treatment based on this, the PDA. And what was the medication that was used? Benedictus. Somebody has told Benedictus, yes, but selective early treatment. Baby Oscar. Yes, it was a Baby Oscar trial which has used the selective early treatment strategy. What was the medication that was used in Baby Oscar? Yeah, ibuprofen. Okay. Any idea what was the primary outcome of the above mentioned trial? Yeah, no difference. I agreed. Somebody has written no difference. Yes, there was no difference in the primary outcome, but we should know before that now what was the outcome? What was the outcome that was studied? BPD was a part of a primary outcome, but not exactly the primary outcome. Okay, we'll go through the answers. So, yes, combined mortality and BPD. Somebody has answered finally rightly. So it was a PDA. We all agree this was a growing pattern of the PDA. So you should know about these patterns. So this is completely non-restrictive PDA. This is something which is the pattern of the restrictive PDA or the PDA which we don't have to treat. This we have talked about. It was a bidirectional flow. And this was a right to left shunting of the flow, which we usually get in the cases of the tricuspid regurgitation, pulmonary hypertension. And these are the parameters which you all have guessed mostly correctly. The ductal diameters. Again, have a certain classification which was based on these various diameters. These are ductal diameter, LAAO ratio, diastolic flow in the descending aorta, the retrograde flow of diastole in descending aorta and the celiac and the cerebral arteries and the left ventricle output. So this is something which as by default, many of the physicians used it as a definition of hemodynamically significant PDA. This is something in a very short about the baby Oscar trial, which was done as a selective surfactant, a selective treatment for the PDA, and the drug which was used was Brufen. The primary outcome was the death and a BPD, combined death or BPD, and they could not find any difference at 36 week of post-menstrual age. So it was BPD and mortality as a combined outcome. Okay, the last question for you guys. Now identify this chart. Yeah, so most of you have answered this. This is HNNE, Hammersmith Neonatal Neurological Examination. Yes. Can somebody tell what are the components? How many components are there? What are the components which are there? Tone, reflexes, sensorium. Somewhat correct. 34. Yes, somebody has written correctly that there are total 34 items which were grouped. 34 items grouped under 6 categories. This I can give you the hint. 34 items somebody has already written among you, and there were 6 categories or 6 components. This also somebody has written. So what are those 6 components? Okay, so all of you have answered in bits and bytes. So there are total 6 components. This consists of tone pattern, reflexes, movement, orientation, and abnormal signs and pattern. So total 6: tone, tone pattern, reflexes, movement, abnormal signs and pattern, and the last one is orientation. So total 6. Okay. What is the importance of this tool when it is used in infancy? Not in neonatal, but in infancy. You have something which is called as Hammersmith infant neurological examination also. Prognosis, yes, but what prognosis? In terms of what we wanted to know about a prognosis, neurodevelopmental outcome, but this is quite broad. Can we concise it and tell? Cerebral palsy prediction, yes, correctly said. So we are more worried about motor. Yes, now comes the answer. Motor. We are more worried about motor sense. Yeah. So it is a predictor of cerebral palsy, or it is going to give you more information about the motor functionality of the person. Okay. Can you name some another tool that will be used, that can be used in the high risk infants with same or more better accuracy? Any other tools? Bailey, HINE, ASQ. Okay. What else? Like in the similar neonatal age group? GMA. Very good. General body movements. General movements. Any more guesses? Rasi. Okay. But we are talking about neonatal age group. What are the better predictor tools for the cerebral palsy? MRI. Yes. Yes. Neuroimaging can also give you a good answers to this. Okay, let's go through the answers. So it is an updated version of the original Dubowitz. So this was made by Dubowitz. It is the modification of a Dubowitz. Somebody has written Ballard actually in the chat box. It is not Ballard related. It is related to an original Dubowitz neurological. It's an updated version of the original Dubowitz neurological examination. Again, this was when it was formed. It was formed in the healthy term babies at that particular moment of time. Okay. Uh, there are total 34 items. This you have already guessed correctly. And we have already said that they are based on the 6 categories: tone, tone pattern, reflex, movements, abnormal signs, orientation, and behavior. So they were the 6 categories where all these 34 items are actually distributed. This is what I actually mean by when I asked you about the cutoff values for the predictions. So it is important because they have given us, even if you don't remember these values, at least remember that these HINE score at a variable age group, like 3 to 6 months, 6 9, and 12 months, they can actually help you predict the risk of the cerebral palsy. So if you have a Heinz score of less than 73 at 6, 9, and 12 months, there is a high risk of cerebral palsy. But if you have a score of less than 40, it's almost always indicates cerebral palsy. And we know that cerebral palsy is something which is related to your motor system. So a scoring at 3 to 6 months can help you guess the GMFCS scale later in the life. So it is going to tell you regarding the cerebral palsy and the GMFCS scoring. Even if you don't remember these scores, at least remember what you are actually predicting. Lesser the score, at least remember this value of 40, that less than 40 is always bad. And it is going to indicate higher indication of the cerebral palsy or a GMFCS scaling, where the patient dependency is going to be quite more. Okay. Now, why this is a tool for an early prediction of a cerebral palsy? Previously, we used to say that we cannot guess the patient with a cerebral palsy till 2 years of age. This is what we used to read it by default. But now there are tools which are available which can tell you that yes, this patient is at a risk of cerebral palsy even before 5 months. So MRI has a sensitivity of prediction of 86 to 89%. General body movement has a beautiful sensitivity of 98% in prediction, HINE of 90%. And after this 5 months, MRI, again a good sensitivity, HINE, again a good sensitivity. And then there are certain scaling like developmental assessment of young children. Whatever scaling that you are talking about, the Bailey, the Dasi, they are quite, extensive tools to be used. But this is something which you can do it on your bedside and on your OPD basis. And this can actually help you predict the cerebral palsy even before the age of 2 years, which we actually, as by default, think that yes, this is a time when we actually going to label the patients as a case of a cerebral palsy. So this is all which we have in an OSCE for today. Thank you. Over to you, Dipen, sir.
Thank you so much, Dr. Gunjana Madam, for very informative OSCE session. And I also congratulate our 3 students who presented the cases nicely. I also thank Dr. Urvi Madam for monitoring first 2 cases. I think we are 46 minutes past the cutoff time, but I think we have done a great learning session. And I am thank you everyone. And I thank IIT Feed Program for giving me the opportunity. Thank you, Dr. Gunjana Madam, and thank you, Urvi Madam. And I wish good night, everyone. And we will have a next program next Wednesday. Till that, see you, everyone. Thank you, ma'am. We are officially closing the program now.
Thank you, sir.
Thank you, ma'am. Thank you, sir.